So I think it'd be good just to make a start, just to honor all of our speakers and make sure we stick to some timekeeping. Just for everyone, my name is Sam Quinn. I'm the Transformation Fellow for ICS at London Northwest, and I'm going to be chairing today's meeting. I'm just really excited to hear a little bit more about how we as physiotherapists can better help patients with sickle cell disease. And so just to keep some housekeeping in the beginning, just if you're not speaking, if I can ask if you please turn off your mic, mostly because we're trying to record this session. So just please note that we are recording the session, and that by staying online, you are consenting to that process. So just mics off, and then we're not going to take questions while the speakers are speaking. If you've got questions, please put them into the chat and I'll ask them on your behalf at the end, or if our meeting is quite small at some stage, perhaps allow for some conversation amongst afterwards. But you are welcome to contact any of us afterwards, just if you have questions that you didn't feel were answered, or if you're wanting a bit more clarity in terms of things. So just to welcome our first speaker, who is Mercy Ibidapo. She is a consultant haematologist at London Northwest University Healthcare Trust. She undertook her training in internal medicine and haematology at Lagos University Teaching Hospital, and then she did an MSc in haematology at the Royal Postgrad Medical School at the University of London. Her special interest in haematologies have hemoglobinopathy. Sorry, we have data back to our undergraduate days. So we really are looking forward to a wealth of experience coming from Mercy. So welcome, Mercy. We're really looking forward to what you have to share with us today.
Thank you very much. Today I'll be talking about sickle cell disease. I will go through the introduction to the disease, the pathophysiology, clinical features, and management, including the role of physiotherapy, as little as I know. Sickle cell disease is the first molecular disease that was described, and it's caused by it's a form of autosomal recessive. Some people sometimes call it co-dominant, just because the hemoglobin S under some adverse conditions can manifest, but largely it is considered as autosomal recessive. It's a single point mutation in the beta chain of a hemoglobin. In terms of definition, you have the sickle cell disease, you have to have two variant hemoglobins, so two abnormal hemoglobins, one of which must be an S. So examples of sickle cell disease include HBSS, that is otherwise called sickle cell anemia. And then you have the S beta 0 thalassemia, where an individual acquires the S from one parent, and the beta 0 thalassemia, where there is no production of a beta chain of a hemoglobin at all. And so these individuals cannot produce hemoglobin A, and they're same severity or similar severity to HBSS people. Then you have the S beta plus, where they produce some amount of hemoglobin A of between 15 and 20% in West African variant, and so it has a milder clinical course. The more hemoglobin A, the less severe the disease is. Whereas the Asian variant, the amount of hemoglobin A produced is quite small, and so it's a more severe disease. So other forms of sickle cell disease include hemoglobin SC, SD Punjab, SO Arab, just to mention a few. Like I said, it's a single nucleotide mutation in the beta globin chain, which is located in chromosome 11. The beta chain has 141 amino acids, and in the 6th position is where the problem is, where is in the DNA, you're supposed, if in the normal hemoglobin A, you have glycine, adenine, and glycine in the codon. Whereas for sickle cell people, you have the threonine replacing adenine, and that codes, instead of for glutamic acid in hemoglobin A, it codes for valine, which is less soluble compared to hemoglobin A. And then for the hemoglobin C, as another example, you have the glycine here being replaced by adenine, and instead it codes for glycine, and that's just all the problem that happens. So this is just illustrating the GAG, GTG here in hemoglobin S, and the AAG in hemoglobin C. And so it codes for, instead of glutamic acid, valine and lysine. Now, in terms of epidemiology, sickle cell disease is, as we know, is hereditary disease affecting mostly people of the Caribbean African, Mediterranean, Middle Eastern, and Asian descent. If you look at the map, you see that if you look at the map of distribution of Plasmodium falciparum, you find that it has a similar distribution to these areas. And so that brings on the concept of balanced polymorphism, the protective effect of Plasmodium falciparum in the hemoglobin AS people, otherwise called traits and carriers, such that once the red cell with hemoglobin AS is infested with a parasite, the red cell breaks. And so this prevents accumulation of parasitemia. And so the individuals with hemoglobin S will not die from severe Plasmodium falciparum, whereas AA people will die from this malaria parasitemia. And hence the distribution is similar to that of malaria because of this survival advantage of hemoglobin AS people. Now, in terms of pathophysiology, in the deoxygenated form, the hemoglobin S is less soluble. And so it precipitates and polymerizes, forms long fibers within the red cell that deform the red cell. It gets deposited in the red cell membrane and make the red cell membrane more fragile. It also causes leakage of fluids out of the cell, and so there's red cell dehydration. It also increases abnormal adhesion of the cells to the endothelium using other different ligands to attach to the endothelium. Then it recruits a participation of inflammatory phenomenon on a global activation of all cells. So all other cells are involved eventually, including the neutrophils, the monocytes, and they all get attached to the endothelium. And as a result of the fragility of the cells, there's a consumption of nitric oxide and due to hemolysis. And this is, contribute to some of the complications. So this is just a pictorial illustration of the fibers in the red cell that deforms the membrane. And hence, instead of a normal, nice donut-shaped cells, you have this banana, or otherwise called sickle shape of red cells. Now, what are the clinical effects? What are the clinical consequences of this deformity? Is multisystemic. There are three major effects. One of them is vaso-occlusion. So, like I said, stickiness, and this results in pain crisis. If it happens in the chest, you have the acute chest syndrome. If in the cerebral vessels, you have stroke. And then if it affects the blood supply to the head of the long bones, particularly the femur or the humerus, it causes avascular necrosis of the bones. Then it's also the same basis for the liver disease, hepatopathy, the nephropathy, and then the chronic sickle back, and also the chronic pain syndrome, as well as sickle retinopathy. Now, you also have, because of the damage to the membrane and the breakdown of the red cells, there is anemia, such that the lifespan of the red cell is reduced to 10 to 20 days, as opposed to 120 days in hemoglobin AA people. So the bone marrow is very active and, turning over cells very rapidly. Then anemia can also result from what we call splenic sequestration, where the spleen enlarges and harbors the cells, and so the cells are not available for circulation. So it's like a sort of hypovolemic state, which is quite deadly, and particularly in children, and such that mothers have been taught to recognize. One of the things we teach the mothers in clinic, how to feel for the spleen, and such simple measures have been life-saving. The anemia can also result from a plastic crisis due to parvovirus infection or folate deficiency due to high turnover in the bone marrow. Then because of the hemolysis, they can also have increased bilirubin, and hence a lot of these children, some of them can be jaundice, particularly if they're unwell. But over time, the bilirubin, clog up, and form stones within the gallbladder, and you have gallstones. Now, because of hemolysis, there is a use of nitric acid consumption. There is increased vascular tone, which causes the pulmonary hypertension within the lungs. And then it's also the basis for priapism, which is a painful penile erection, which if prolonged more than 4 hours can risk erectile dysfunction. And then it's also the same basis for leg ulcers. Then there's the issue of increased risk of infection. As early as first year of life, the spleen does not work, even in the sickle patient. Whether it is eventually reduces in size or even increases in size, the spleen does not work. And with time, as a result of recurrent sickling within the splenic artery, there is eventual autosplenectomy, which is shrinking of the spleen. Now, because the spleen doesn't work, there's a risk of infection, particularly with encapsulated organisms, the pneumococcus, meningococcus, and H. influenza, and hence we advise that these patients are vaccinated against these organisms. And it's also the basis why we give them penicillin prophylaxis. Then there's osteomyelitis, which most of the time is due to Staphylococcus. But if you find Salmonella, Salmonella is the next common organism. But in any individual that you find Salmonella osteomyelitis, you can bet that that individual is a sickle patient. If the genotype wasn't confirmed before, you need to check such an individual for evidence of sickle cell disease. There are suggestions also that there is impaired cell-mediated immunity defect in sickle patients. So this is a pictorial representation of the multisystemic disease. So here I have the acute complications include meningitis, which can be due to meningococcus, like I've said, or pneumococcus. Then they could also have stroke, particularly in children. I'll talk a little bit more about stroke later. They can have a sickle hepatopathy, the gallstones, papillary necrosis, another complication where the papilla of the renal tubules is infarcted out, and then the individual can present with painless hematuria. Then there's priapism, there is bone marrow infarction, particularly during acute pain crisis, especially in association with parvovirus infection. And it can lead to systemic fat embolism, which is quite fatal. Then they could also have osteomyelitis, then retinal infarction, acute chest syndrome, acute chest crisis, septicemia, and splenic infarction and sequestration. The chronic complications, neurocognitive impairment. This usually, hence we monitor the neurocognitive assessment, but usually done by the psychologists. Yeah. Then raised bilirubin, kidney injury, delayed puberty, erectile dysfunction, retinopathy, pulmonary hypertension, cardiomegaly. A lot of sickle patients have cardiomegaly as a result of the anemia, ongoing anemia, and diastolic heart failure is what they tend to have. Chronic anemia, mentioned about that, leg ulcers, and chronic pain. These are triggers for sickle pain crisis, because sickle cell pain crisis is by and large the most common form of acute complication that they have. And you see when a lot of them present in A&E, the greatest percentage, probably more than 90%, is as a result of pain crisis. And the precipitants are usually infection, dehydration, hot and cold weather. In hot weather, they sweat a lot and they get dehydrated. Cold weather, the direct effect of the cold, particularly the speed in relation to the speed of the wind, is a recognized precipitation of pain crisis. And then any condition that reduces the oxygenation level. You remember I mentioned that in the oxygenated state, the hemoglobin S becomes less soluble. Excessive physical activity, and then stress, particularly emotional stress. So in terms of management, well, naturally we would avoid the precipitating factors. We ensure adequate hydration when they come in. We give them potent analgesia like opiates and treat associated infections. For the chronic pain syndrome, of course, they have analgesia in the community, different strength of analgesia, including opiates in some cases. Then we also use what we call the cognitive behavioral therapy that tends to sort of help with the coping mechanism. I'm sure you tell me more about the use of TENS machine, which is electrical impulses to disrupt pain sensors. Further physiotherapy intervention include massage, which is thought to improve blood flow. Also stimulates the inhibitory fibers, which help to reduce the pain. Then, of course, use of aquatic and land physiotherapy have been known to improve range of movement and muscle strength. Now, we have the acute chest syndrome. This is an X-ray of a patient with acute chest syndrome. It's sort of new bilateral radiological changes with or without fever. And there are different degrees of shortness of breath or hypoxemia associated with acute chest syndrome. It's usually due to infection or infarction, and oftentimes we may not be able to distinguish between the two, and so we advise sometimes, if applicable, to treat for both. Sometimes you can be sure that it's pulmonary embolism, where you have evidence of embolism on a CTPA. So in terms of this, of course, the physiotherapist is helpful to prevent acute chest syndrome. So once they come in with chest pain, we make sure we optimize their analgesia, and we give them incentive spirometer, which helps to prevent it. And even following the acute chest syndrome, we use incentive spirometer to improve their oxygenation and help the recovery. Stroke is common in children. Like I said, the most common age is between 4 and 10 years of age, and is sickling in the intracerebral arteries. There's the fact that a child has a stroke is quite debilitating. You can imagine this little lovely boy with a smiley face developing stroke. It's a lifelong debilitation, and particularly there's a risk of recurrence. So we put them on long-term transfusion and reduce their hemoglobin S percentage to less than 30% at all times. In terms of physiotherapy, they help, rehabilitation to reduce muscle wasting, stiffness, and associated spasms, and improve the function of the residual muscles. In terms of prevention of the stroke itself, we screen the children between the age of 2 to 16 years with what we call the transcranial Doppler ultrasound scan, and we have different categories and interventions to institute. And in that way, we have been able to reduce incidence of stroke in these children. Avascular necrosis is sickling in the ligamentum teres. It's most common in the femoral head, but it can also affect the shoulders and the spine. It often gives chronic pain. Physiotherapy is definitely very helpful, especially when it's happening in children or even in adults when they are not quite ripe for hip replacement or shoulder replacement. They benefit from physio and appropriate analgesia, including neuropathic agents. But the ultimate treatment is a joint replacement. So this is just an X-ray of a classical example of avascular necrosis of the femur. Then we have a chronic sickle back, which is due to recurrent sickling and hemopoietic stress in the end plates of the vertebrae. And this leads to collapse of the end plates, giving a fishbone appearance. So if you look here, I'm not sure if it's very obvious. If you look, there's a depression here. Okay, maybe this one will show it. So there's depression of the lower end plate of this vertebral body, and the lower one, and you see the shape actually looks like a fishbone. So that's what we see on a plain X-ray of the back. This is a lateral view. And then, so overall, management of sickle cell disease is multidisciplinary. In terms of the medical management, we use folic acid because of the high turnover of cells within the bone marrow to supplement folic acid as essential vitamin. And we start this within 3 months of birth. Yes. And then, of course, penicillin prophylaxis and increasing doses through age, and then appropriate analgesia. We offer blood transfusion, which may be in form of top-up transfusion or red cell exchange transfusion, as may be appropriate and depending on the indication. Hydroxycarbamide is a medication which has transformed sickle cell disease and is in use for over 25 years. Patients actually observe noticeable improvement in their health and exercise tolerance once they are responsive and they are compliant with hydroxycarbamide. New medications are coming into place. Crizanlizumab is an agent that inhibits P-selectin, one of the ligands that the cells use to stick to the endothelium. So we're hopefully going to start to use this. And then there's an agent, voxelotor, which shifts the hemoglobin dissociation curve within the red cell such that they are able to hold on more to oxygen than before, and therefore thereby reducing rate of hemolysis or sickling process. In summary, complex symptomatology, multisystemic, and the role of physiotherapy cannot be underestimated. They help with acute chest syndrome, chronic lung disease, chronic pain, and chronic sickle back, as well as after an incident of stroke.
That was a really great explanation, just giving us an overview of the pathology around sickle cell. Are there any questions, any comments? I've been monitoring the chat, hadn't seen any. I've got some of my own, but just if there was any questions from anyone. Okay, so I'll start off with mine. I was just wondering, I noticed that you said that exercise or excessive exercise could be a precipitating factor. Is there some guidelines in terms of what would be what would precipitate a crisis, or is it really patient specific?
Yes, I think it's patient specific, but you know, the patients, some of them they're so well, they go to gym 5 times a day. But I always tell them that if you go 5 times a day and you realize that you're now coming down with crisis, you need to cut it down to 3 times a week. I mean, sorry, 5 times a week, then cut it down to 3 times a week. So they have to stop titrate it to their own tolerance. But we always discourage competitive, what do you call it? Competitive sports. Yeah, because that's a lot more tasking than recreational. Yeah.
Okay, so encouraging sort of recreational activity, but really avoiding.
Yes.
Okay,
yes,
and then just monitoring how they're feeling, and then based on that,
they can then titrate it. Yeah.
Yeah, pacing and that sort of thing. Okay, fantastic. And then I just had a particular question around AVN. I noticed you said patient may present with AVN in the spine. As a physiotherapist, I'm quite familiar with looking out for AVN in the shoulder or hip, less so in the spine. What would you say we should look out for, other than the very obvious signs of pain or perhaps neurological changes if it's quite advanced? Are there some things that you say, gee, that would be something just as a flag or an early warning sign that this might be something to be mindful of with a patient presenting perhaps say with back pain in an outpatient setting?
I think if they're presenting with back pain, if you do a plain X-ray of the back, then you see the sickle shape, and then you see osteonecrosis there. Some of them would have the sclerosis affecting some aspects of the spine. Yeah, okay. Similar to what you see in the head of a femur.
Okay, so if I understand correctly, would you say that if you're treating a patient with sickle cell in a medical history, you would expect to view a fairly recent X-ray? Would that, because sometimes they might present to physiotherapy without a recent X-ray and we can't refer for imaging. What would you say should be an acceptable time frame to have a look at the most recent X-ray, sort of 6 months ago, or would you want a more recent X-ray?
Because these changes are chronic. Yeah, so even an X-ray 6 months ago should, for somebody presenting to yourself, because we're not going to refer them as soon as they start having the pain. So it's something that is sort of ongoing, and we think that when we've given them a lot of pain relief and it's becoming persistent, then we'll refer for physiotherapy. So I would say 3 to 6 months should be fine.
Okay, great. So if we have a patient arriving in clinic, they haven't had an X-ray sort of in the last year and they've got significant back pain, it might be an indication that they need an X-ray.
X-ray, yeah.
Okay, fantastic. Great. Are there any other questions? Any comments? I can't see any hands raised. Thank you, Dr. Many of our patients. Oh, there, Lola's just put one in. Many of our patients have hypnecrosis. That's okay. I'll read out the comments and then just if anyone wants to comment on it. Many of our patients have hypnecrosis from a very young age, but orthopedic surgeons will not consider surgery until they reach a much older age. Would they benefit from physio? And for how long?
I think the issue of when to do hip replacement is always a tricky one. I attended a lecture where they said you can actually exchange you can replace a hip at any age. But practically speaking, Lola is right. The orthopedic surgeons are reluctant to do hip replacement because after some years, because the child is growing, the cavity increases in size and whatever prosthesis they put there might get too small with age. So they're always very reluctant to replace these joints in children. So definitely physiotherapy helps. Yeah.
Okay, brilliant. Fantastic. Thank you very much. Really appreciate a very interesting topic. And we're going to move on to Zara Ewing. She's going to be talking to us about general exercise principles for patients with sickle cell disease. Just to introduce Zara to you. Zara is a specialist haematology physiotherapist at Imperial College Healthcare Trust. She's been working in haematology for the speciality of haematology for the last 5 years, and she has experience in both chronic and acute pain in multiple settings. She has joined Imperial to further her skills in managing acute as well as chronic sickle cell pain, and at the moment she is developing an outpatient pain service for people suffering with sickle cell. So really looking forward to your talk, Zara, and just the same as for a Mercy talk, if you have got any questions, please put them into the chat, especially as we're going along, so try not to leave it all right to the end, just you might miss that opportunity. So yeah, thank you. Looking forward to your talk, Zara.
Thank you very much for introducing me, and thanks for your amazing talk there, Mercy. So as Samantha said, I'm Zara, and I'm one of the physiotherapists at Imperial. So I'll just be going through the acute side to sickle cell disease, specifically physiotherapy assessment and management. So just starting with assessment and management for acute sickle pain. So with our patient population, it's really important that we sort of go for quite a patient-centered holistic approach. I know that we try and do that with all of our patients, but specifically with sickle cell, these patients have this condition as far as it stands at the moment, lifelong, and it's really important that we empower them and allow them to lead their care. They are the ones that know their bodies best, and they often have quite good insight around what's brought them into hospital as well. So when we're sort of working with them and assessing them, it's really key to really gaining that good rapport with these patients, is to really empower them and sit down and listen to what they're saying. There are obviously circumstances as well, which I will come on to eventually, which is when patients have sort of acute needs and are presenting with quite concerning symptoms. Then obviously we'd focus on that at the time. But for example, if you're seeing a patient in a sort of an outpatient or clinical setting, and there isn't any urgency regarding time in that first assessment, I really do think I gain a lot from spending time with the patients and really getting to know their understanding of their pain. So just thinking about sort of pain history, this is sort of the key that will really guide the rest of the assessment. So I tend to sort of split it into what I call the 4 W's. So thinking about sort of what type of pain, and when you're asking them about pain, I try to ask them about both acute and more persistent pain, or what they may refer to as their chronic pain. It's important that we sort of identify the difference between the two, because it will guide what we're doing with the patient at the time, and it will help us to identify if there's other things that we need to either follow up for them or focus on in the session. So sort of breaking down what the patient says, I'll ask about type of pain, which includes the intensity as well. So generally I'll go for sort of a visual analog scale rating for most patients. There are other tools that you can use out there, but just when you're first meeting them, it'll give you some rough idea around how their pain is. Keep in mind that some patients may have quite high ratings of pain at baseline, so they may be living with quite significant pain. So just taking a rating for that, but also thinking about any acute pain. And then sort of coming on to the when, we're looking at sort of onset. So when did the pain start? It's quite easy when speaking with patients who have sickle cell disease to for them to sort of get focused on one particular pain, and it's just when we're there, it's trying to sort of guide and navigate them towards what's appropriate for your particular assessment as well. So identifying the onset of the acute pain, which is possibly what you're seeing them for, and then also taking note of when more persistent pain started as well. And again, that's something that, you know, there may be a lot of information, especially in the hospital setting, already documented in their notes as well. So then you'll be able to go back and compare that. With regards to sort of when as well, sort of asking them around, is it getting better? Is it getting worse? Is it staying the same? So with their acute pain, we need to know if the analgesia that they're prescribed is actually taking effect. With regards to sort of management of pain, it is an MDT approach, and although the medical team are responsible for the prescription of their pain relief, as a team, both, you know, the nurses, physiotherapists, occupational therapists, all of the staff, it's really important we're checking in to make sure that the pain relief they're receiving is actually adequate to cover. And this is actually part of the guidelines as well, both at Imperial but and across the NHS. And again, sort of the next key point would be looking at sort of where their pain is. So looking at location, asking them around whether it radiates or whether it's just presenting in the one location. With regards to sort of chest pain, this is really key, and we'll kind of go on to this a little bit more, but knowing if the patient is presenting with, say, central chest pain versus thoracic pain versus chest pain that's radiating up towards their shoulder might influence actually what's causing that as well. And just considering sort of location of pain and keeping in mind when you're going through that sort of body map with the patient, looking at which ones are acute pains and which are more persistent. And then sort of the last part would be looking at why. So looking at sort of what the triggers were, what does the patient feel has caused this acute pain to come on. And again, as Mercy went through, there are quite a few triggers for sickle related pain. Often it can be just something as small as a patient going out into the cold weather, becoming dehydrated, infection. There's lots of things that can trigger it. So just asking them around what they feel has contributed to that. So we can sort of get some idea. And again, that links in with looking at their acute versus more persistent pain as well. And I'm sure Rebecca will touch on that a bit in her talk. So yeah, again, sort of going through your assessment, it's important to really get a good, clear history in regards to the patient's pain, and this really will direct your objective assessment. And keeping in mind that we need to really empower the patients, because they are the ones that know their body the best and they do know their pain. And the more we empower them, the more they will engage with us, and we can help to better manage their pain overall. And I guess this sort of links to the next point, which is establishing goals. Now, again, as physiotherapists, occupational therapists, all professions, we do sort of try to work towards what the patient's aiming for. But when it comes to sort of management of sickle cell patients, it's important that we establish a goal in the first session, and that can actually even be achieved within the session. Quite often, that's a good way to get some gauge on sort of how to progress your input and your treatment, and keeping it patient-centered as well, and goal-orientated will help to sort of guide as well further progressions as you go along. And again, with regards to our assessment, it's important that the sooner we involve the rest of the MDT, the better it is for our patients. So, for example, if the patient says that their trigger is, say, stress, or there's appears to be a psychological element, I generally recommend referring to a psychologist sooner. A lot of our patients are connected or are aware of the psychology services available, but if not, trying to sort of signpost them to that as well. Because again, if stress or a psychological aspect has sort of brought them into hospital or has triggered their pain, we can only do obviously so much, and we can try and support with that, but it's trying to look at sort of the root cause for their pain and then how we can try and get on top of that as soon as possible. And sometimes psychology input is a big aspect to that. So just sort of touching on the next part, which is sickle cell related comorbidities or complications. And I know Mercy's gone through quite a bit of that so far. I've just tried to sort of lay out acute versus chronic, and there is some overlap between the two. With sickle cell, there are a lot of potential complications. So again, our assessment, first guided by our subjective, but then going into objective, can be really key to identifying some of these. There are sort of three main types of sickle crisis that a patient can present with. So there's your vaso-occlusive crisis, which is tissue injury from ischemia caused by an obstruction to the blood flow. Secondly, there is aplastic crisis, which is when the bone marrow temporarily stops the production of red blood cells. And then the third most common sort of cause of presentation is hyperhemolysis, which is that acute drop in hemoglobin, which is due to destruction of the red blood cells. So those can all trigger these various acute presentations. And then with regards to chronic, that some of the impacts of having had those acute events can lead to the more chronic changes. Keeping in mind sort of our assessment as therapists, we're sort of looking to identify if we know a patient has had an acute complication before, keeping in mind what that is and identifying if that's linked to the current presentation or not. So looking at their symptom history and what's brought them in and seeing if that matches up, and also just keeping in the back of your mind any more chronic complications that we know the patient may already have. Another key aspect, just while we're on the topic of comorbidities, is things like acute renal failure. So just in the inpatient setting, trying to identify and pick up on those sorts of things as early as possible, and liaising with the doctors if we're seeing signs and symptoms that indicate towards that. Same with sickle retinopathy. So again, as physios and occupational therapists, I'm sure when we're going to see people, we'll be asking a lot of questions around function, but just looking to see if they report anything that indicates maybe a change in their vision, or also if they're reporting eye pain to you, impaired or blurred vision, or anything unusual about their eyesight, keeping in mind that is a potential complication as well, and one we do need to act on quickly. And with regards to sort of the orthopedic side, so there's acute versus chronic side of this as well. And again, I'm aware Mercy's talked a bit about this already, but from our acute side as a physiotherapist, commonly we do see osteomyelitis, and chronically we do see avascular necrosis, or also known as osteonecrosis, which is damage to the bone tissue from temporary or permanent loss to blood supply. When we're sort of going through assessment of those sorts of pains, the patient may be sort of reporting to us more of a pain that gets worse the longer they're weight bearing. And again, they'll be sort of classing that perhaps as one of their more long-standing pains, but again, looking to see if that's changing. And sometimes we might be the first one to pick up on bony changes as well. So again, talking to your medical team will be really important. And if you're concerned that the patient's presenting with, say, early signs and symptoms of avascular necrosis, it's important that we recommend that the appropriate assessments sooner. So looking to see if they can get some scans and imaging done. Just sort of coming on to the last key comorbidity that really physiotherapy is involved with, again with sort of respiratory and looking at acute chest syndrome. So we'll touch on that just coming into the next slide. So with regards to our objective assessment, there is sort of, this is going to be, as I've kind of talked about so far, guided a lot by what the patients told us subjectively, but also what we know from their history. So having a really good read through their notes before seeing them will allow you to know what the patient's pre-existing complications are, but also where the focus needs to be for their treatment. When I go to see patients as well, I tend to sort of go through the sort of the whole body, but I focus in around the areas which they're reporting acute pain or may influence my assessment. So looking at signs and for joint abnormalities and swelling, so looking out for any abnormalities that you notice. This can be a sign of undiagnosed complications, but also it will affect our management with regards to exercise prescription. When you're assessing them as well, consider their risk of upper and lower limb DVTs, and again, try and rule this out as soon as possible. In the acute setting, this is probably a little bit easier. In the community-based setting, you'll go through your standard protocol for management of that. And again, sort of coming on to the next part, I would be looking at sort of assessing range of movement, both active and passive, and strength as appropriate. Again, just trying to identify what is acute pain that I can help to manage, what is more persistent pain, and are there any undiagnosed complications that we haven't picked up on sooner, and looking at appropriate assessment of that. Another sort of key aspect to objective assessment in the acute setting is respiratory. So with patients who are presenting with acute sickle chest pain, I always recommend that you complete a full respiratory assessment, and especially assessment of saturations on mobilisation, because again, patients who are presenting with acute sickle chest pain are at increased risk of acute chest syndrome. And the sooner we pick that up, the better the outcome for the patient. And again, we want to try and prevent the need to transfer to ITU or anything like that. So sort of going through your objective assessment with regards to respiratory. So you'd complete a full respiratory assessment, but some of the warning signs to be looking out for are, again, abnormalities in their respiratory symptoms. So if you're seeing if they're reporting shortness of breath, cough, dyspnea. With regards to chest pain, are they reporting central chest pain? They may sometimes report the pain as being thoracic or in the upper abdomen. And again, this can all be signs leading towards an acute chest crisis. They'll often describe the pain as sort of a heaviness in their chest, and it may possibly radiate as well. If they're reporting to you fever, or they're tachycardic or tachypneic, or there's signs of hypoxia. Those are all key signs and symptoms leading towards potential acute chest crisis. If you observe that, then it's important that you alert the medical team straight away. There is standard protocol and guidelines as to what assessments need to happen. With us, I recommend that we speak to the team and ask for an ABG if a patient's saturating at less than 95, so if the SpO2 is less than 95% on room air, or it's dropped by more than 3% off their baseline, then they are at increased risk of acute chest syndrome, and you could be starting to pick up on that. So they do need an ABG in that scenario, and that's as per the guidelines both at Imperial and for NHS England. You'll find that sort of if you're concerned about acute chest syndrome and the medical team are investigating, they will order a full workup. So that will include a chest X-ray, full blood count, your basic biochemistry, so creatinine and liver function, and a cross match. And they may also do blood cultures and sputum cultures as well, because again, we want to differentiate whether it is acute chest syndrome or whether it is a chest infection or other cause as well. So once we've sort of gathered some idea on sort of our individual patient, and I know we've got people listening from many different settings, we need to sort of, I guess, tailor our management depending on that. So sort of setting the respiratory side of things aside for just the moment, coming back to more that acute versus chronic pain and the assessments we may have done, looking at how do we manage their acute pain. The key thing is to ask if pain relief is optimised.
2 minutes.
Okay, thanks, Samantha. So looking at making sure that their pain relief is optimised, but also trying to minimise side effects. So we're just trying to strike that balance, and again, feeding that back to the rest of the team. Keeping your care holistic and patient-centred, so directing it around their goals and what they want to achieve. The focus really should be around achieving function first in the acute setting, so the patient being able to do basic aspects of their ADLs, or at least being able to transfer, and then sort of gradually building up on that from there. With regards to management of acute sickle pain as well, if you're prescribing exercises for a patient, if you've ruled out any other complications, thinking about making sure the exercises are well paced, and again, this is key in sort of managing, trying to manage the risk of pain flares whilst the patient is in hospital or in the acute setting as well. And if the patient is reporting that their pain is flaring with any exercise or advice we've given them, then we need to sort of explore that a little bit more. Or even if they're, say, reporting their pain is flaring with just simply transfers, are there intrinsic and extrinsic factors within the setting, the healthcare setting, that are influencing that? So trying to identify those as early as possible and reducing those. So looking out for things like drafts and open doors, even things like that can be influencing your assessment and also the patient's admission. So with regards to principles of exercise, before starting any exercise with sickle cell disease, I always advise that the patient should be adequately hydrated and make sure they have water nearby. So that's in the acute setting as well as the community. Consider the environment they're in. So again, trying to identify any factors that may trigger a sudden temperature change and try to minimise those. Pacing the exercises is key, making sure you plan for breaks for the patient. High intensity and high resistance level exercises are generally not appropriate for these patients, and considering whether they've rested well and timing your session around appropriate sleep and rest. And then again, touching on what we talked about at the start, psychological factors may influence their pain, so trying to reduce things that trigger stress for the patient, and also involving the psychology team as soon as possible if that is a factor for the individual. Yeah, there's sort of with regards to exercise, there's no sort of hard and fast patient should do these exact specific exercises. It's just more we need to consider the right principles and just basing it around sort of how the individual responds to the exercise and tailoring it for that individual. Again, as we know, exercise is highly beneficial, and for many reasons. For our sickle patients, it will help with their pain, but it can also help with some of the other complications they may encounter, such as avascular necrosis, and also with sort of maximising their respiratory function as well. So with exercise for them, for patients who suffer from sickle cell, it's important that we work them to the level where their symptoms are controlled and we're not triggering their pain. So I generally say they shouldn't be in pain at all ever during exercise, but again, within 3 hours afterwards, if they're experiencing pain and it's in the same area where they have done exercise, then they've probably done a little bit too much. So again, we want to try and make sure that they're getting the benefits from exercise, but their symptoms aren't being triggered. And again, if we are triggering their symptoms, there's that increased risk of vaso-occlusive crisis occurring in that area as well. So just to sort of summarise with regards to exercise, we really want our exercises to be goal orientated and functional. And I do suggest, especially in that first session, trying to develop a goal, and ideally one that you can achieve in that session or within the first 1 or 2 sessions. For acute sickle pain, always start with gentle exercises such as range of motion and stretching. Aim to achieve full range of motion before progressing to strengthening, and with strengthening it should be gentle and low resistance. Heavy weights and high level resistance are generally not appropriate for most of these patients, and making sure that they have adequate rest in between. The last key point I'll just mention is that when you're working with sickle cell patients, it's really good to close with relaxation, as it allows them a good recovery, but also it can help for those that have stress as a factor contributing to either their acute or more persistent pain. So again, I've gone through sort of the key points, but do consider any sickle-related comorbidities, rule out any undiagnosed comorbidities, do assess your saturations on mobilisation for patients with sickle chest pain, and lastly, consider the medications your patient's on and the potential side effects that they may incur as a result of that, and how that influences your assessment. Thank you very much.
Excellent, brilliant. Thank you, Zara. That was a really great reminder just to be mindful of patients' comorbidities when treating. That's the whole MDT's responsibility. So thank you for that. Zara, will your slides be made available to this group?
Yes, yeah.
Okay, fantastic. Because I think just some of those things, some of your points on exercise, I'm sure are really relevant and important, and I'm sure people want to go over those again. Thank you so much. We'll come back to questions for Zara and Rebecca. We'll put them together at the end of Rebecca's talk. So please do put them into the chat. So I'm just wanting to introduce Rebecca to you, Rebecca Mcloughlin. She is a highly specialised physiotherapist at St George's University Hospital. She works in pain management within the St George's Red Cell Pain Management Service, which, as I understand, is a unique service in the UK, offering tailored care for patients with sickle cell. It's a dedicated service for patients with persistent pain related to sickle cell disease. She is also very busy doing an NIHR pre-doctoral fellowship, and the aim of her research is to look at non-pharmacological pain management through co-production with people living with sickle cell disease. So it sounds like a really exciting piece of work that you're undertaking, Rebecca, and looking forward to reading some of those publications that I'm sure will come from what you're doing there. So great. And you're going to be talking about assessment and management of persistent pain associated with sickle cell disease.
Yes, thank you. Thanks, Samantha. So yes, I'm going to follow on from Zara's presentation and think a little bit more about physiotherapy input for people who are living with persistent pain associated with sickle cell disease. And particularly in my talk today, I'm going to think more about management than assessment, which I think we've covered fairly well. I will touch on it a little bit. but really trying to think about the type of work that I might do in our service at St George's and how that might relate. Hopefully the examples that I give will show how that might relate to physiotherapy input in different settings. So before I do go on to think about the clinical examples, I just wanted to highlight a few important points from the sickle cell literature regarding persistent pain and pain management approaches. So the first thing is to note that although acute pain has long been recognised as the hallmark of sickle cell disease, persistent pain is now widely acknowledged as present and significant for many people living with sickle cell disease. Within the sickle cell literature, persistent pain is often described as pain that's present on most days over a period of 6 months or more. And this description makes me think about the way that persistent pain is often described in the context of sickle cell disease. And in my work with people with sickle cell, often they might say things like, oh, well, it's the daily pain or it's the everyday pain that I just live with. And while this language really clearly describes the frequency and the persistent nature of chronic pain in sickle cell, it does very little to acknowledge the severity and the significant impact that persistent pain in sickle cell, in conjunction with acute crises, can have on all aspects of people's lives. So it's really helpful, important, and good to see that persistent pain in sickle cell is being increasingly recognised. So another really helpful point that Osunkwo and colleagues highlight in the paper that I've referenced here is that persistent pain in sickle cell disease may be present in one or more locations and with or without contributing disease complications. And I think for many people with sickle cell in the past, their experience might have been that if there wasn't sign of a disease complication that could explain presence of persistent pain, it was harder for their persistent pain experience to be recognised. And I think that it's really helpful and important that we recognise that we don't have to have evidence of ongoing or current contributing disease processes to be experiencing persistent pain. So in terms of management of persistent pain, recent evidence-based guidelines produced in the UK and in the USA do advocate for management of persistent pain with cognitive behavioural approaches like Mercy recognised, self-management approaches and use of pain management programmes. But both guidelines also recognise that further research is really needed in this area, because there is a very small number of papers looking at these approaches within paediatrics and young people with sickle cell disease, but there's a real absence of direct evidence for adults living with sickle cell disease. And the guidelines that we currently work with are largely taken from extrapolation of evidence from other populations, such as fibromyalgia and back pain, chronic back pain. So hopefully in the future, some of this evidence will emerge specifically within sickle cell populations. So for the rest of today's presentation, I'm going to give some examples of case studies, people that I've worked with within the pain management service at St George's. These examples, they're based on real cases that are obviously anonymised, and I have made some slight changes to further anonymise them. And I hope that through presenting these cases, this will illustrate aspects of pain management that physiotherapists are maybe already integrating into their work with people with sickle cell, but perhaps also give ideas of other approaches that it might be helpful to use. So the first case that I'm going to discuss is that of a 55-year-old female who has the genotype HBSS, sickle cell anemia. She presented with multi-system sickle cell related complications or problems. I won't go through them all, but you can see that there was really widespread impact in some terms of multiple systems and joint challenges. In addition, she was classified as medically obese, and she really had very significant mobility issues following total hip replacement and due to severe bilateral osteoarthritis. And the impact of her altered lower limb mobility kind of had a very big impact on her upper limb function as well. So mobility was a really big issue. And she would mobilise indoors with crutches and outdoors with a wheelchair. She came into our service on a background of regular admissions to hospital, often quite lengthy admissions to hospital. At this point, she wasn't on disease-modifying treatments, which was her choice. And in terms of her social situation, she lived with a carer, had a very supportive partner, and a son and grandson who lived quite locally and whom she really wanted to have practical kind of contact with regularly. So when we first met and we started to talk about her goals, her initial physiotherapy goal was that I want to be able to walk better. So we spent some time thinking about what walking better would mean to her personally. And she identified that walking better would be about walking a little bit further, but also being less scared of falling. We pinned down, we thought about, well, how much further is further? How much do you need and want to be able to walk? And she recognised that actually if I can be more independent around my flat and get to my wheelchair, then that's a realistic goal for me at this point, and that would be valuable and worthwhile. And we did spend some time together really kind of highlighting the why, like why would this be valuable? Why would it be worthwhile? We thought about the personal goals that were the personal values that were underpinning her goal and what achieving that goal meant for her. And it was interesting that for this lady, she'd learned to walk again after her stroke in her 30s, and walking really linked for her in terms of independence and a sign of her personal strength and her ability to keep going in the presence of long-term condition. And so it had real meaning for her that she could move around independently. And it was also a very related goal to life with her grandson, and she really lit up when she talked about him and about being able to be active with him. So there was real meaning behind this goal for this lady. So how we might often approach a goal like this in pain management physiotherapy is to look at the challenge and do some kind of experiments to gather a bit more information about the challenge that someone is facing. So we did a few brief walking experiments, and what we tried to do was really notice what was happening when this lady was walking, not only in terms of physically what was happening, but how she felt, the thoughts that were coming up, other changes that she was noticing in her body. So we really understood the whole kind of event. So what we noticed was that on walking very quickly, pain increased. And she noticed the thought, I need to get this walk over with. So immediately the focus came on to where am I getting to and how quickly can I get there? I need to get this over with. So understandably with this thought, she would try to increase her speed. And as she increased her speed, she kind of pushed down more on her elbow crutches. She became more stooped in her posture. She was really racing to get to the chair. And she noticed that as her posture changed in this way and she started to rush a little bit more, her pain significantly increased and she would feel a sense of panic. She would then notice that her breathing altered, that either she would hold her breath or she'd start breathing much more rapidly. And this really understandably fueled and perpetuated this cycle. So by looking at this in detail, we were able to notice the various components that were impacting her ability to walk. And importantly, we were able to make sense of the fact that it was understandable that she was avoiding walking. We were able to normalise, well, if I was experiencing all of that when I walk, I might avoid walking. This is a really understandable pattern to be in, but it's not helpful at the moment because it's not enabling you to reach your goals. So together, we were able to start thinking about where we might target change. And we began to look at experiments and look at strategies that might help to change this cycle and produce a more helpful cycle. The first area that we targeted was around her breathing, and this was something that she could practice without walking, that she could start to work on, as Zara said, quickly in that first session, and that she could practice regularly and do without needing to be in session with me. So we looked at the rationale for calming, slowing and deepening her breath. We talked about how the threat response might encourage more rapid breathing, but a soothing, calming breath might calm the nervous system and reduce that sense of threat. And once she understood that rationale, she had a really clear motivation to practice with that, and it became a really useful strategy for lots of situations. We then looked at thoughts and pain, and the thought around whether she expected pain to be present when walking. And over time, she was able to reach the conclusion that pain is likely to be present on walking, and that pain is present all the time. And so the expectation or the hope that walking might be pain-free shifted slightly in a helpful way that gave a bit more flexibility about walking. She started to talk more about, well, I know that I'll be in pain, but I think I can help reduce the additional pain if I do some helpful things. So the concept of her kind of expectation around pain and walking started to become a little bit more flexible. We also started to pay a bit more attention, less attention to how quickly can I get to the chair, and more attention to how's this going? What's my posture like? What's my walking like? How am I managing it? And she started to notice that it was helpful to pause when she began to stoop and bend forward, because that triggered the less helpful cycle. So when we integrated a bit more pausing in the walking, we naturally fell into a more paced walking pattern, more breaks, slower speed, and there was a reduced sense of panic, which helped to feed into a more helpful, more sustainable and less unpleasant cycle. So by doing this, she was able to practice short walks a little bit more regularly, and through that regular practice was able to build up her tolerance to the extent that she'd hoped, mobilising a little bit more independently around the house, but also maybe more importantly, mobilising more confidently around the house. So this is an example of where in persistent pain management, we might use a cognitive behavioural based kind of approach. So within physiotherapy, we're really familiar with thinking about the body, mechanics, movements, behaviour, how we're doing something. But from a pain management perspective, we might also pay a little bit more attention to the thoughts that are arising in a certain situation, the emotions and the interplay between those four domains. And this gives us a little bit more kind of insight into the situation and also more targets for change. So the second case study that I'd like to talk about is a case of a younger gentleman, a 23-year-old male nursing student with the genotype HBSC. And he was referred into the service following a period of increased pain and hospital admissions in the last 12 months. And he was describing a daily pain in his back and legs that increased after long periods of standing. And in addition, episodic crisis pain that he described as beginning in the chest and spreading into his arms and legs. He recognised classic kind of triggers that we've talked about already today in terms of changes in the weather, stress, and factors on his placements such as working in cold operating theatres or temperature changes moving around the hospital. In terms of the impact of the persistent pain that he was beginning to experience, he talked about the worry and stress associated with missing hours of his placements and study time. And he'd also stopped dancing and exercising, which were things that he'd previously enjoyed. So what we looked at first of all, again, was the kind of the pattern to find out more information about what was going on in his particular circumstance. And we noticed, or he described, that during his course, and particularly when he was on placement, he might be standing for long periods of time or sitting for long periods of time studying. The thoughts that came along with these activities were often around, I've got to get the hours done, I've got to keep going, I've missed time already, I can't miss any more, I've just got to kind of plough on. So he would notice early signs of pain, but his tendency would be to push through, to keep going, to carry on. He would notice an increased feeling of stress as he was trying to do this, and he recognised that that could further increase his pain. And he would tend to go around this cycle until the point that unfortunately he kind of crashed, in his words, and would need a few days either at home or increasingly in hospital to recover. So we decided that it would be helpful to think a little bit more about the pattern of this activity and the pattern of his activity and pain over time. And so together we produced a bit of an illustrative graph to look at a kind of an average week for him. And what we noticed was that on his placement days, activity was essentially just really high for a block of a few days. Long periods of standing, long tiring days, challenging situations in terms of his learning, but also physically challenging and sometimes stressful situations, understandably. So following a block of a few placement days, he was increasingly falling into a pattern of needing recovery days at his weekends or his days off. And he described how on these days he would often or increasingly spend the whole day in bed, and that had a significant impact on his mood. He didn't want to be doing that, he didn't want to need to do that, and it added to stress about what he wasn't doing during that time. We also looked at his study days at home, and actually they were kind of quite high activity days as well, in that even though he was sitting for very long periods because of this sense of lack of time and the unpredictability of his sickle cell and when the next crisis or flare-up of pain might come. Again, he was feeling the need to really pack in as much study as possible, and he was often sitting for many hours working before he'd get up and move around. So because of the context of this situation, of someone who is doing incredibly well to hold down a demanding course and to keep going, we were very aware of making manageable changes to this pattern. So we thought together about, well, where might the easiest change come? And we thought that, first of all, looking at his days when he was studying might be most helpful, because these were the days that he had most independent control over. So on these days, we introduced pacing, a timer for his work, encouraging standing for any parts of his work that he could, and sitting, integrating more movement, integrating little bits of stretch. And we introduced the idea of movement snacks. So a minute of dance, or a minute of marching on the spot, or a short period when the kettle's boiling of just moving around a little bit as he was doing that other activity, getting those little snacks of movement into his day. We then looked at his days off and the recovery days, and again we looked for how we could integrate a little bit more helpful movement into those days. So times when he was in bed, were there any small stretches or movements that he could do to break up those long periods of lying? We also introduced some breath practices because he recognised what he described as kind of washing machine thinking, lying there and thoughts going round and round in his head. And so we introduced some breath and mindfulness practices to try and bring his attention away from that and towards the breath. And we worked on recognising what he had achieved that day, and it emerged that sometimes the days weren't entirely in bed in the way that he described them, but because they didn't meet his hopes for the day, it was hard to recognise the small achievements that he was making. And then finally, we looked at his placement days and introduced more stretch and movement and breath practices during his shift. And it was really interesting that I thought this might be one of the hardest areas for him to work on, but actually he found it very easy. And despite being someone who didn't really talk to his colleagues about his sickle cell and his pain, he didn't find it at all daunting to think about integrating some stretch and movement into his day at work. And he quite enjoyed that people asked him about it and were interested. And he talked about some other people kind of getting on board with the idea as well. So that made his placements a bit more rewarding in some ways and enabled him to connect with his colleagues. So hopefully those two brief examples have given you a little bit of a sense of the way that we might work in physiotherapy in terms of persistent pain management. And I just wanted to highlight a few specific kind of themes that often emerge alongside usual physiotherapy assessment. So in persistent pain management, we pay particular attention to the description of someone's pain experience, the whole experience, and their beliefs, what the pain means to the person, why they think it's there, what they think might be helpful, and what they think hasn't been helpful and why. So there's a lot of focus on the why behind these things. We pay a lot of attention to the biological, psychological and social impact of pain, the triggers and influences, the factors that might affect it. And we also pay a lot of attention to the biological, psychological and social strengths of the individual. And I think within a condition like sickle cell, it's really important that we recognise the resilience and the strengths and the learning that people bring to physiotherapy. We work on collaborative goal setting, values-based goals, and we're really focusing on long-term behaviour change strategies. So the development of habits or patterns that promote well-being, physical function and mobility in the long term and are sustainable for people. We reflect on learning from experience, good and bad. I'm aware of you, Samantha, and I'll stop soon. We focus on skills to manage setbacks, and we recognise and reinforce achievement. So just to say that sometimes the work feels a little bit like being alongside someone as they face the reality of living with sickle cell disease, which can be incredibly unpredictable, demanding, difficult, challenging. And so a lot of the work that we do is very long term. We achieve this work, we do this through individual appointments, group appointments, pain management programmes and a regular drop-in movement group that we run every week. We do have a YouTube channel that's got a little bit more information about some of the groups and things that we run. And that's it. Thank you.
Brilliant, brilliant. Thank you so much, Rebecca. That was fantastic. Just having a look and seeing the incredible work that you're doing and just how we can apply our really going back to, I hate saying basics, but going back to really what most of us would have learned at university, which is that patient-centered care, to actually a very complex group of patients. So just applying those holistic care principles in practice. So any questions, please feel free to ask. I see Lola's got one. She says, should routine physio assessment be part of the MDT preventative service provided for this patient group? Either of you can feel free to answer.
I think it makes me really curious, Lola, about the service that you've got. I think it would be ideal, it would be lovely to have physiotherapy at that first preventative kind of point. Within our service, the pain management part of the service is quite small. I'm there 2 days a week. Our psychologist is there 3 days a week. So we're not at every MDT kind of appointment. So we don't quite have that yet, but I think it would have a huge amount to offer. You know, it's really stood out that sickle cell disease is a multi-system, lifelong condition with huge impacts. So the whole MDT's got a role, and the earlier that could come through in clinical appointments, the better, I think.
Sorry, I just wanted to comment because it occurred to me that we always seem to be treating when problems have already happened. And I just feel, you know, if we're doing assessment, maybe we can prevent some of these, you know, avascular necrosis. I know that sickle is the problems you can't prevent, But if patients actually understand what they can do, you know, from a physiotherapy point of view to prevent these complications happening, to me, it's a no-brainer. I mean, it's the same thing we were saying about diet and nutrition last week when we had a lecture on that subject. And we're all thinking, hold on, we just keep treating people when they've got problems. Why don't we try and find a way of avoiding some of those problems if we can?
Yeah.
Just a thought.
And I think from a pain management point of view, we are looking more at transition and working with young people, teenagers and young adults to think about pain management in that more preventative kind of way, to think, yeah, let's not wait until someone's in their 30s and really struggling. Can we teach some of these strategies and share them a bit earlier? Exactly.
Brilliant. Thank you. Something for the future.
And I guess that sort of with regards to the assessment that we can do in the acute setting, we might not be able to necessarily prevent, but we can intervene early to try and prevent their sort of conditions progressing any sort of as quickly. For example, with osteonecrosis, avascular necrosis, we can intervene early and give them appropriate exercises which can help in their management and hopefully reduce how soon they need a hip replacement or something like that. That's what the evidence shows at the moment anyway, and that's what the guidelines say. So that's sort of, I guess, where most of our role is sitting, and it sounds like sort of similar to what Rebecca's saying with where things are at the moment. But yeah, certainly something to consider for the future.
Definitely. Zara, I just had a question for you, perhaps just one question. I noticed you said that just having a look in the acute setting that you need to be mindful of upper limb DVTs. I'm not sure that everyone would be mindful of what the red flags would be for that. I think most of us are quite familiar with lower limb. What would you say you need to look out for in the inpatient setting?
So similar sorts of symptoms as you would for lower limb DVTs, but just more, it's more likely to be around sort of the bicep region. So you'd be looking for like heat, redness, swelling, and localized to that area. But again, that can be a sign of osteomyelitis as well. So if you're noticing anything like that, it's important that you obviously talk to the medical team and recommend further review and possible imaging as well to rule that out. And again, we can, I guess, identify whether we think it's more likely to be DVT versus something like osteonecrosis, because we know, osteomyelitis, because we know that's infection related. We'd be looking to see, does the patient have a fever? Are there any other abnormalities in their blood counts? So looking at their daily bloods and looking to see if there's a rise in their CRP, things like that as well. So you can sort of bring the picture together. Does that sort of answer your question?
Yeah, that's brilliant. Thank you. Thanks for that, Zara. And then just Rebecca, one for you. I was just noticing with your patient-centered approach to patients, I think sometimes it can be quite a challenge, especially perhaps in an acute setting where there's pressure in terms of discharge and you don't have the time that you might normally have. Could you suggest, I mean, it might be a bit difficult and maybe it's putting you on the spot, you can come back to me on it. Is there a question that you think if you ask this question, this would really help, or there's a turn of phrase that's quite helpful? So I know for me in outpatients, one thing that helped me with directing conversation was, instead of saying what's wrong with you today, or what's your pain, you ask the person, why have you accessed me today? Or so is there something along those lines that you could suggest as like a little tip or trick? I know that it's more complicated than that, but sometimes having a little trick up your sleeve is quite a nice thing to have.
I guess what pops into my head is that it might be something about if there's one thing that could have a significant impact in 6 months' time, you know, like if there's one area that would make a big difference to your life in terms of movement or activity or whatever, what would the priority be? You know, because often there are so many things, aren't there, that you could work on, but in an outpatient setting where you say, you know, you've got quite limited time with someone, maybe doing one thing really well and learning about the process of change and noticing, oh, well, this is how I establish a change in this area. You know, maybe that builds the skill to then be able to apply that to other challenges. So I'd maybe think along those lines.
Brilliant, brilliant. That's it. I'm gonna use that one. All right, fantastic. Thank you very much. I'm gonna hand over just to Lola in a second for just to give us some announcements and just some thanks. But just a really great afternoon. Thank you, Dr. Ibidapo, for a fantastic overview of sickle cell pathology and disease. And then Zara, just reminding us again of the importance of being really mindful about the pathology and comorbidities around patients, that we really are part of that MDT. We're not just there as therapists. We're there to have a critical eye and keep a lookout as a safety net for our patients. And then Rebecca, just reminding us, going back to the very foundational skills that we should all have in terms of patient-centered care and seeing the patient as aside from their disease, their pathology, but actually as a person, what are their goals for their treatment, and just always keeping the person in mind while working through the disease process. Great, I'll hand over to Lola.
Thank you, everyone. That was absolutely wonderful. You know, I like I said, these are not areas that I haven't thought about in the past, other than to think about necrosis, and we refer them to the orthopedic surgeons, and that's about it. So this has really opened my eyes, and I hope it's the same for everyone. So as Samantha says, you know, to thank all those who've participated, Dr. Ibidapo, Zara, Rebecca, and Samantha for chairing so efficiently. I'm usually very poor at chairing, would have been going over by at least 10 minutes if I was chairing. So I think we need to give Rebecca, you know, a clap for thank her for keeping us on track. Also thanks to Ralph, who coordinated everything for us and sent out all the invites. He will be in touch again because, as you know, this sessions are being done through the Haemoglobinopathy coordinating centers. This is where the West London Sickle group. So we'll really appreciate getting some feedback from all those who attended, so that we know whether these sessions have been useful, what you particularly liked or what you thought we could do better, and whether these will be of use to you in your practice. So it's quite important. He's going to send around either a paper form or Survey Monkey, and we'll really appreciate if everyone can complete that for us, so we know whether we need future events of this nature and whether it will be of use to you. So thank you, everyone. Samantha says we must finish on the dot of 4:30. And so, as usual, I've gone over by about 30 seconds, so I apologize. So have a wonderful evening for the rest of the evening, and we look forward to seeing you all again in future events. We do have other events coming up, and we'll keep you posted. Thank you. Thanks, everyone. Well done.
Thanks.
Well done, Zara. And Rebecca and Dr. Ibidapo.